Good afternoon. I'd like to thank SAGES for the invitation to present. I have no disclosures for this presentation. In the 1990s, acute pain was part of a significant number of physician visits. In response and in an effort to improve the quality of pain treatment, pain became the fifth vital sign in 1995. Unfortunately, as a result of this attention on the treatment of pain, it has contributed to the ongoing opioid epidemic in the United States. Surgery is an environment that exposes patients to opioid medication, and 10% of opioid-naive patients are still on opioids at 1 year postoperatively. Previous studies have identified specific operations and prescribing practices that contribute to chronic postoperative opioid use. However, data on benign, minimally invasive foregut surgery is lacking, which leads us to the purpose of our study, which was to determine if patients who undergo minimally invasive benign foregut surgery are at risk of progressing to persistent postoperative opioid use, and if so, to identify specific patient and surgery risk factors. In order to do this, we used the IBM MarketScan database. All adult patients who underwent elective fundoplication, hiatal hernia repair, or Heller myotomy from the years 2010 through 2018 were included in our analysis. Chronic postoperative opioid use was defined as at least 33% of the proportion of days covered by opioids for 30, 90, 180, and 365 days postoperatively. A total of 17,530 patients met our inclusion criteria. 6,895 of those patients underwent fundoplication, 9,235 underwent hiatal hernia repair, and 1,400 underwent Heller myotomy. 65 patients were identified as having persistent opioid use at 1 year postoperatively. 33 of those patients had undergone fundoplication, 29 hiatal hernia repair, and 3 Heller myotomy. Surgical procedure and indication for surgery were not associated with a risk of chronic postoperative opioid use. Similarly, age category, region of surgery, and sex were also not associated with chronic postoperative opioid use. Interestingly, a lower Charleston comorbidity index and a prior mental illness or substance use disorder were relatively protective with respect to a risk of chronic postoperative opioid use. In conclusion, minimally invasive benign foregut surgery is associated with a very low risk of persistent opioid use at 1 year postoperatively. Lower Charleston comorbidity index scores and a history of previous substance abuse and mental illness were statistically but not clinically significant in protecting against the risk of chronic postoperative opioid use. Additional studies are needed to determine how to replicate these results for other general surgery operations.